A 2-month-old baby present with jaundice. He has elevated conjugated bilirubin level. Diagnosis is confirmed by the cholangiography during surgery. What is the best course of action? Patient suffering from the jaundice, 2 months, but elevated conjugated bilirubin. This point is very, very important. First of all, conjugated and non-conjugated. Conjugated, that means the liver cell is the normal. That means within the liver cell, we know within the liver there are a different type of the cell, and the conjugation occurs within this liver cell, and after conjugation this bile goes to the common bile duct, so it is the normal position. But in case of this baby, there is this conjugated bilirubin is increased. That means there is pathology in the common bile duct or bile duct. So bile duct pathology, there is atresia or absence of the common bile duct. So what happens, the conjugation is complete, but this bilirubin cannot goes to the common bile duct, so it goes to the blood, and there is the elevated blood level of the conjugated bilirubin. So what can we do here? The options are the insertion of the PTC, choledochoduodenostomy, ERCP, Rho and Y protozonostomy, and liver transplant. So what can we do? So first of all, let's see the normal pathway. Here we can see this is a liver. In the liver, normally what happen in the liver, the conjugation occurs. That means the unconjugated bilirubin, this is the unconjugated bilirubin goes to the liver, and it converted into the conjugated bilirubin. So liver function is normal, but when this conjugated bilirubin goes to this common bile duct, it is not possible in this baby. Why? Because there is the obstruction is the common bile duct. So what can we do? We have to remove this part. That means the disease segment where there is the obstruction. So what can we do? What is our next option? So we can resect this part, and what we can do, we can add this part with this intestine. So let's see. So here we can see the operation. Here we can see this is a normal liver, this is a liver, and there is the common bile duct or bile duct started. So what we can do, we can anastomose this bile with the small bowel, and here we can see the small bowel connection to the drain bowel. So small bowel, it is connected to the bile duct or common bile duct, or the right or left hepatic duct, and from there the bile goes to the small intestine. Again, in this picture it is very, very obvious that here this is the liver, and this part, it is the small intestine, and this small intestine, it is connected to the bile duct. So this portion of the bile duct is removed, and then small intestine is connected to rest of the duct. Now see how it happens. It occurs 1 in 17,000 baby. Biliary bilirubin is obliterated by the inflammatory cholangiopathy, causing progressive liver damage. So it occurs, there is obliteration of the biliary pathway. That means the common bile duct, right or left hepatic duct, they are obliterated or obstructed, and it present in few weeks of the life. No family history of the liver disease in this condition. Jaundice in infant present when it is more than 14 days, and also present with pale stool, yellow urine, which is normally a clinical feature of the all individuals suffering from the jaundice, and it is associated with cardiac malformation, polysplenia, and situs inversus. And what is the management? The early recognition is important to prevent liver transplantation. That means in earlier stages there is no liver damage, liver cell are okay. So if we can diagnosis in the early phase, it is very possible to prevent the complication and liver transplantation. So we have to give the nutritional support of the patient, and Rho and Y protozonostomy. The protozonostomy, that means the small intestine, which is the jejunum, and portal part, they are connected. If Kasai procedure fails or late recognition, liver transplantation may be option. So when early diagnosis is not possible or Rho and Y jejunostomy fail, in this condition liver transplantation is the only option. So what is our treatment option? Our treatment option, first of all, proto jejunostomy or Kasai procedure or liver transplant. So what is our best course of action? First of all, Rho and Y proto jejunostomy. And other option here, such as the insertion of the PTC, it is not possible. Cholangioduodenostomy, it is also not possible because the common bile duct is totally obliterated. ERCP had no role because there is a long segment stricture, so ERCP cannot dilate this long part. And liver transplant is one of the treatment option, but it is the final treatment option. First of all, we should go through this Rho and Y proto jejunostomy.